Hello, hello. So today we're going to be talking about substance-related and addictive disorders, focusing primarily on substance use, but we will talk a little bit about some addictive behaviors towards the end. So before we get into our clinical diagnoses, let's take a second to talk a bit more about non-clinical substance use, which would be substance use that's low to moderate in nature and is not associated with any socio-occupational types of problems. There are a couple things to consider in terms of determining whether or not regular old substance use has a likelihood of eventually being associated with problems, and at which point may start to transition over into substance abuse, substance dependence, something that we would consider to be clinical or diagnostic. A few of those things include legality. So even if someone is using an illegal drug like cannabis or marijuana, for instance, in a fairly healthy way, like perhaps only using the drug in social settings and moderate amounts, because that is an illegal drug, that does increase the likelihood of future problems by way of legal or financial problems. So even if use of an illegal drug is relatively healthy in nature, the illegality of the drug increases the likelihood of problems. That's one thing to consider. Another thing to consider is culture. Different cultures have different rules and laws relating to substance use. The example of this I always give is the legal driving limit for alcohol consumption. Different countries have different legal BAC limits, ranging from zero tolerance policies that you might see in Pakistan or Saudi Arabia to more lenient policies like you may see here in the United States, where you can legally drive as long as your BAC is beneath 0.08. So we could have someone who is engaged in the same behavior but be in two different places and be fined in one scenario, or be in prison in another scenario. Another determinant or potential determinant of possible problems associated with substance use is biological sex. Males and females do process alcohol differently for a variety of reasons, and you can see that represented in the graphic on the upper right-hand side of the screen, showing how the number of drinks and the amount of time that those drinks were consumed over will differently impact the BAC of a 25-year-old 175-pound male versus a 25-year-old 130-pound female. There are a couple of different reasons why females are impacted more significantly by alcohol consumption. Some of that has to do with size, some of that has to do with body composition, but some of that also actually has to do with relative amounts of alcohol dehydrogenase in the body, which is an enzyme that contributes to the processing and breaking down of alcohol. Females biologically have less of this enzyme than males, so those are some reasons why it is easier for females to get to a high illegal BAC level quicker than males. In terms of diagnosis, so moving on from substance use to something that we would consider to be clinical, there are a couple changes that we observed between the publishing of the DSM-4 and the DSM-5. When the DSM-4 came out, we had broadly speaking, two different diagnoses that we could render if substance use kind of crossed that line and started to become problematic or have a physiological impact on the body. We could either diagnose a person with substance abuse, which would be when use begins to be associated with persistent problems like legal problems, financial problems, social problems, occupational problems, et cetera, et cetera. Or we could diagnose a person with substance dependence, which is when the body has begun to physically depend upon the substance in order to function. At this point, we'll see indicators of tolerance and withdrawal, which are two terms that I'll expand upon later on today. Fast forward to 2013 in the DSM-5, substance abuse and dependence have been combined into a single substance use disorder, which is a combination of the symptoms of both abuse and dependence kind of taken together. So clinically, as far as diagnosis goes, we no longer distinguish between abuse and dependence. We just indicate that substance use has begun to become disordered. And this is because in many cases, folks who have a dependent problem also have indicators of abuse. And so the two really were very comorbid. And so that's one of the reasons that we kind of shifted towards the singular approach. In addition to that, we could also diagnose a patient with either intoxication or withdrawal associated with a substance. These two diagnoses are defined by the presence of physical symptoms versus behavioral symptoms. So we're not talking as much about a person doing things differently with respect to a substance, like using a larger amount or for a longer period of time than intended, but instead we're talking about physical symptoms like increased heart rate or blood pressure, things like that. Usually, if you're working in a clinical setting, like a private practice or a group practice doing therapy, you're not really going to be using the intoxication and withdrawal codes that often, because if someone is coming in for therapy associated with a substance use disorder, it's unlikely they're going to be actively intoxicated or in withdrawal. And if that is the case, you would likely be referring them to more of a medical setting. So instead, these two diagnoses are typically limited to those medical settings or inpatient units. So where a person has gone away to rehab, you might see these diagnoses used upon admission, or similarly, you might see these diagnoses used in like an emergency room. These can be used as independent diagnoses, so you can simply diagnose a person as being intoxicated or in withdrawal, or they can be used as comorbid diagnoses alongside the substance use disorder label. As far as being related to other disorders, substance use labels do definitely crop up. This particular graphic is comparing the frequency with which intoxication and withdrawal of various substances in addition to the substance use disorder, and how those various diagnoses overlap with different types of disorders within the DSM. So you can kind of scroll down vertically to see different types of substances, and then scroll across horizontally along the x-axis to see different categories of disorders, and then kind of see, you know, where you're more likely to see intoxication of different substances versus withdrawal, versus areas where you're more likely to see that the substance use disorder is persisting. So this is just kind of informative, interesting graphic that shows the overlap between different types of disorders and different types of substance use disorders. So let's move on to the diagnoses themselves and talk a little bit more about what those criteria are. Up first, we have substance use disorder. Note that I have substance in quotation marks, which is not something I typically do when introducing a new disorder. This is because technically what you would diagnose a person with would not be a substance use disorder, but would instead be an alcohol use disorder or a cannabis use disorder or a tobacco use disorder or an opioid use disorder, et cetera, et cetera. We would not be diagnosing a substance use disorder. Instead, we would replace the word substance with the name of the substance that the person is being impacted by. That being said, the criteria of an alcohol use disorder and a cannabis use disorder and an opioid and a tobacco use disorder, the criteria are really all the same. The only thing that differs is the substance in question. So rather than showing you guys, 4 or 5 slides that are all basically the same, I'm just going to present the criteria once, but just know, for future reference, one, if you are considering going into one of the mental health professions, but more proximally than that on the exam, what you would be diagnosing is not a substance use disorder, but instead we would replace the word substance with whatever the name of the substance is that we're talking about in that particular scenario. So the diagnosis here is relatively simple. We're really just looking at problematic use of a substance leading to distress or impairment, which is manifested over at least 12 months of time and is indicated by 2 or more of the following 11 symptoms. So the substance is either taken in larger amounts or over a longer period of time than intended. The person has tried to cut down, they want to cut down, but they've been unsuccessful in doing so. They spend a lot of time obtaining, using, and recovering from the substance, so it's taking more and more time from their day. They're exhibiting cravings. They are failing to fulfill major role obligations. So, not going to class, not picking up a child from daycare, not clocking in at work would all be examples of failing to fulfill role obligations as a student or a parent or an employee. Continued use despite persistent social or interpersonal problems. So substances getting in the way of healthy relationships, or maybe even a friend, family member, partner has expressed concern and the person is not changing their behavior. And so that's really starting to weigh on the relationship. Activities being given up because of use. So this person may stop doing other things they enjoy to spend more and more time on the substance. The person may continue to use in physically dangerous situations. Best example of this would be driving under the influence, or maybe dangerously combining drugs, things like that. The person may continue to use despite knowledge of a problem. So again, someone else might point out, hey, we're concerned. The person may have been arrested, which indicates a problem, but continue to use. The person may be in therapy, have a therapist pointing out the problem, but continue to use. And then finally, we may also observe tolerance or withdrawal, which I'll expand upon more here in a moment. So a lot of different symptoms. And again, we really just need to see 2 of these consistently over 12 months. So it's not, one symptom for a couple months and another symptom for another few months. It's really at least 2 of these consistently, more time than not, over a 12-month period of time. And as I mentioned earlier, the criteria of the substance use disorder are very behavioral in nature, and you're going to see that juxtaposed against the more physical types of symptoms that we'll talk about when we get into intoxication and withdrawal later on. So before we do that, though, let's take a closer look at the pharmacological criteria, the pharmacological criteria being tolerance and withdrawal. The reasons that these are referred to the reasons these are referred to as pharmacological is because we're really dealing more with changes in how the body is responding to the substance versus purely kind of behavioral, a person doing things differently as a consequence of the substance. So both of these are kind of 2-pronged definitions, so 2 pieces to each term, pretty easy to remember. Tolerance is when a person needs more of a substance to achieve the same effect, or they'll experience a decreased effect without increasing use. So to give you an example of this, let's just use something simple like alcohol. So let's say that we have a client who previously would have 4 drinks. That could be 4 beers, 4 glasses of wine, whatever. A person has 4 drinks in a night and begins to feel drunk. They've kind of gotten, if they've developed a tolerance, that means they've gotten to a point where maybe they need 6 or 7 drinks to get to that same place rather than getting drunker. Or if they stick with the 4 drinks, now they're getting a decreased effect. So they're not feeling the same intoxication level that they were feeling before. Withdrawal is when a person experiences physical symptoms due to substance concentration decreasing in the body. So this means that as, again, using alcohol as an example, as the amount of alcohol decreases in the body, the person actually starts to feel symptoms. And this is different than how use typically works. Typically, we see symptoms as a person becomes intoxicated, but once a person's become dependent, we start to see symptoms as they start to become sober. Typically, we'll see this associated with with prolonged or heavy use, and the specific symptoms do depend on the substance. So we'll talk more about physical symptoms of intoxication and withdrawal as we go through different substances, because they do vary depending on what the drug is that we're talking about. And so ultimately the person ends up taking the substance to avoid symptoms. So an example of a common symptom associated with alcohol withdrawal, to again use as an example, is, tremor, shaking hands, headache, nausea, things like that. And so a person may start drinking in the morning to make those symptoms go away. We're going to cover several different substances in this class today. Specifically, we're going to be talking about alcohol, tobacco, cannabis, opioids, and stimulants. And those are going to be the terms that you would use when making diagnoses. So if you were talking about a quote unquote substance use disorder that involved any kind of stimulant, cocaine being an example, what you would diagnose the person with would be a stimulant use disorder. Similarly, if you were working with a case that had to do with heroin or a prescription opioid, you would diagnose an opioid use disorder. If you were dealing with marijuana, you diagnose a cannabis use disorder. If you were dealing with nicotine, whether it's cigarettes or vaping, you would diagnose a tobacco use disorder, and then alcohol would be an alcohol use disorder. The video that I have here is one that you guys can watch if you'd like to. It's kind of a funny spoof video that I always show in class, that is kind of poking fun at some research that was done in the late 1940s by two guys named Witt and Peters. Ultimately, one of these researchers was having a difficult time with spiders at his home, making their webs at, I guess, odd hours that he didn't really appreciate, and he wanted help getting them to shift their behavioral patterns towards making webs at a different hour. And so they began giving the spiders various drugs to see if they could change the behavioral patterns of the spiders. And as a result, interestingly enough, what the webs looked like changed as a consequence of what drug the spiders were being given. And while this is kind of a weird story as like an origin story, spiders have actually been used since as a common animal model for studying the effects of substances, because spiders have a similar nervous system to humans. And so this YouTube video is kind of poking fun at that. Watch it if you like a laugh. Otherwise, it's not super critical. But it does touch on a couple of the substances that we're going to be talking about today. First step of those is going to be alcohol. Alcohol is classified as a depressant. So that's one of the first pieces of information I'll give you about each category or each type of substance that we talk about, is what category the substance falls into, and broadly speaking, kind of why it's in that category or how that substance functions. Then we'll go through symptoms of intoxication, symptoms of withdrawal, and then other relevant information relating to that particular substance. So alcohol is a depressant, meaning that it works by depressing the central nervous system. And it does this by increasing the firing of a neurotransmitter called GABA, which is our brain's primary inhibitory neurotransmitter. So by increasing the firing of this inhibitory neurotransmitter, it ultimately inhibits or depresses our central nervous system. And so, unsurprisingly, symptoms of intoxication would include indicators that your central nervous system, your ability to think critically, and executive functioning, that these abilities are decreasing. So we may see things like slurred speech, an inability to coordinate oneself, an unsteady gait, this funky symptom that basically just means one's eyes are twitching called nystagmus, impaired attention or memory. We may also see stupor, or in severe circumstances, we could see coma. And we just need to see one of those symptoms or more in order to diagnose a person with alcohol intoxication. And of course, this symptom would need to be present after the consumption of alcohol. Blackouts may be an associated feature of heavy intoxication, but are not a formal symptom. So that is something that I frequently will get questions about, is how blackouts kind of work into this. Technically, all we're really looking for as far as intoxication goes is impaired memory. So someone not really being able to clearly remember events is considered a symptom rather than a full blackout. Blackouts happen again where a person cannot remember anything during an episode of consumption, but they're not really considered to be a formal symptom. At the end of the day, alcohol intoxication is a really common experience that impacts as many as 70% of college students. But as I mentioned before, it's only diagnosed acutely and in association with problematic behavior, meaning that it's not a permanent diagnosis. It's not something that stays with you like a bipolar diagnosis, for instance, that's considered more chronic. Rather, you would only really be diagnosed with alcohol intoxication during that period of time that you were intoxicated. And what's more is, much like everything else we've really talked about, we're not really talking about diagnosing people simply because they are having an experience, but because they're having an experience that is contributing to distress or impairment. So I'm not like walking up and down the streets diagnosing people with alcohol intoxication, but rather it would be a warranted diagnosis if associated with problematic behavior. Like if a person ended up in an emergency room, then this diagnosis might be used in that particular scenario. As far as withdrawal goes, alcohol is kind of a funky drug in that while it is one of our long-standing legal drugs, it has a fairly complex withdrawal that is actually potentially fatal. And that is something that makes alcohol really unique. There are many street drugs, illegal drugs, that do not have dangerous or fatal withdrawals. And so it's kind of interesting that we have this legal drug that, one might assume that just because we have a drug that's legal, that, it's one of the safer drugs. But that's not necessarily the case, at least not as far as withdrawal goes. So here's how alcohol withdrawal works. There are a couple of different stages. The initial stage that we'll see 1 to 2 days post last drink will include symptoms like hallucinations, which may include something called a formication, which we'll talk a little bit more about in our chapter on schizophrenia. But a hallucination is a false sensory perception, meaning that you are seeing, hearing, feeling, tasting, smelling something that is not there. And a formication is a particular type of tactile hallucination that basically feels kind of like you have something creepy and crawly on your skin. So you're feeling something kind of moving along your skin that's not really there. So we may see any type of hallucination, including a formication 1 to 2 days post last drink. We may also see seizures. 3 to 8 days post, we may see a symptom pattern called delirium tremens. And if we're seeing this, this is an indicator of severe withdrawal. So everything on this slide are indicators of severe withdrawal. These are not things that happen in every instance of withdrawal. These are things we're going to be seeing in dangerous, potentially fatal scenarios. So 3 to 8 days out, we may see this delirium tremens pattern, which is diagnosed by the presence of 2 or more of the symptoms on this list, which include autonomic hyperreactivity, hand tremors, insomnia, nausea or vomiting, again, hallucinations, psychomotor agitation, anxiety, and again, seizures, specifically more the tonic-clonic subtype. Ultimately, 1 to 4% of people going through this process, at least 1 to 4% of those admitted to a hospital, because that's really where we're getting our data from in this scenario, is hospital admissions. 1 to 4% of those folks end up dying as a consequence of this process due to metabolic complications, which include things like hyperthermia or a high body temperature, cardiac arrhythmia, which is an atypical heartbeat, or seizures. And as I mentioned before, there are really only a few drugs associated with dangerous withdrawal, alcohol included. Other ones include opiates and benzodiazepines, or benzos for short. And so for this reason, even though alcohol is a legal drug that is readily accessible, if someone is going through these symptoms, it is recommended that they go to a hospital so that their withdrawal can be physician supervised, because it is one of those things that can be potentially fatal. Interestingly enough, if you do go to a hospital to have withdrawal supervised by a physician, one of the possible treatments that a patient might receive is smaller doses of benzodiazepines, which is kind of interesting given that I just revealed that benzodiazepines also have a potentially fatal withdrawal. So why is that? Ultimately, it has to do with something called cross tolerance, which is basically a fancy way of saying that a person who uses a substance builds up their tolerance to that substance. So in this scenario, we have a patient who is regularly using alcohol heavily, and as a consequence, builds up their tolerance to alcohol. So it takes more and more alcohol to become intoxicated, achieve a particular effect. In doing so, and typically unbeknownst to the patient, they're also building up their tolerance to other similar drugs. And when I say similar, I mean drugs that have a similar mechanism of action. So in the case of alcohol, I'm talking about other depressants that take their effect by increasing the amount of GABA in the brain. And so when you build a tolerance to one substance, you're building a tolerance to other substances that work in the same way, even if you haven't ever used those substances. So in this scenario, we'd be talking about also building a tolerance to things like benzodiazepines, which work in a similar way. Benzodiazepines are a class of pharmaceutical that are used to treat anxiety by increasing GABA. And this includes things like Valium and Xanax, for those of you who are unfamiliar with what a benzodiazepine is. And so when a person is actively going through withdrawal, we know from just referencing the definition of withdrawal that one of the ways to make the symptoms go away is to use more of the drug. But in this scenario, we're trying to get this person detoxed or through the withdrawal process associated with alcohol. So we don't want to give them more alcohol, but at the same time, the symptoms of withdrawal are dangerous and potentially fatal. So what a physician does is they prescribe a smaller dose of a similar drug, in this case, a benzodiazepine, to lessen the withdrawal symptoms while getting the person safely through the process, and then tapering off of that benzodiazepine once the withdrawal from alcohol is complete. And again, this is a physician supervised process that happens in a hospital. And while I highlight the idea of cross tolerance to you guys, using alcohol and depressants as an example, this is a process that can really apply to any class of drugs. So building your tolerance to one stimulant is going to impact your tolerance to other stimulants as well. So that's important to recognize. Alcohol use. So a couple of remaining little tidbits of information before we move on. Alcohol is the most frequently used intoxicating substance across most cultures. It accounts for 4% of global deaths and 4% of global disability. Alcohol use disorders diagnosed most commonly in males. Females are more likely to develop higher BACs due to some of the reasons I stated before, like body size, body comp, alcohol dehydrogenase. But females at the end of the day are less likely to either become addicted or to encounter problems associated with use. And one of the reasons for that really kind of boils back to males being socialized around alcohol use more so than females. We've kind of talked about how females are more likely to be diagnosed with things like anxiety and depression. A lot of that has to do with the fact that our society encourages women to express emotions, and so we're more likely to see many of those diagnoses. And it's not necessarily to say that men never experience anxiety or depression, but we socialize men more so to repress emotion and to express in other ways, such as through the consumption of alcohol. Only a minority of drinkers, less than 20%, eventually develop an alcohol use disorder. So alcohol use is very, very common, and really only a relatively small subset, a minority, end up developing a use disorder. But it's definitely a large enough number that it is an area you can specialize in. And again, you're more likely to see males than females with this particular presentation. Moving on to number 2, we've got tobacco. Tobacco functions both as a stimulant and a sedative. It does this because it increases the concentration of 2 different chemicals in our body, epinephrine and dopamine. So these are the 2 different neurotransmitters that we're seeing impacted. And so epinephrine provides the stimulating effects of tobacco, and then dopamine contributes to some of the sedating effects of tobacco. At the end of the day, tobacco is not a drug that you can diagnose in terms of intoxication, and it's because the intoxication of tobacco in and of itself isn't really something that has associated problems with it, really. There are problems associated with long-term use, and there's certainly problems associated with withdrawal. But as far as the intoxication goes, there aren't really problems there. And as you guys know, if there's no distress or impairment, then there's really no diagnosis. So there's nothing diagnostic in terms of intoxication, but there are symptoms that you will see. Things like relaxation, which would be the effect of dopamine and the more sedating side of tobacco. But you also see things like increased alertness and ability to concentrate, which would be the stimulating side of tobacco and associated with the increase in epinephrine. As far as withdrawal goes, that is definitely something that can be diagnosed more specifically if a person has 4 or more of the following symptoms: irritability, frustration or anger, anxiety, difficulty concentrating, increased appetite, restlessness, depressed mood, or insomnia. Tobacco use disorder is most commonly diagnosed among daily users of any medium: cigarettes, vaping, smokeless tobacco. So folks who are using daily are most likely to kind of cross over into the use disorder territory. Nighttime cravings and smoking within 30 minutes of waking up in the morning are also signs that we're dealing with a use disorder versus more casual use. Vaping has had the effect of decreasing cigarette use from 13% to 1%, and increased vaping use from up to 15% among teenagers. So that's something that I'm sure you guys are familiar with, that, you know, one of the reasons that vaping kind of emerged was to decrease cigarette use and to help long-term smokers transition to a healthier way to access tobacco and hopefully to wean completely off of it. But it's kind of had the reverse impact in that it has, especially among younger people, teenagers in particular, has attracted more people to tobacco use than cigarette use did alone. The common age of onset for tobacco use disorder is prior to the age of 21. It's really rare for people to pick up the habit after 21. So tobacco use disorder is a path that most people who have the diagnosis start on in their adolescent years. People might have their first cigarette or try vaping or something like that for the first time after 21. But in that scenario, it's more likely to be something social in nature, something more casual, something not associated with a full-blown use disorder. People who have the use disorder typically pick up the habit at a younger age. About 80% try to quit, 60% relapse, and only about 5% remain abstinent for life. So it's a highly addictive drug, even though it doesn't have some of the dangerous, I guess, indicators of other substances. Like, just to go back to alcohol, for instance, you know, alcohol intoxication is something a person can be diagnosed with. It's something that can lead to problems. And then alcohol withdrawal is potentially fatal. We don't see any of that with tobacco use, but tobacco is highly addictive and is associated with long-term health consequences, which is one of the reasons we're covering it here. The prevalence of tobacco use, fortunately, has declined in the United States over the past decades, but again, vaping is kind of warping some of that, and that while more and more adults are moving away from the behavior, vaping is enticing more and more teens to try. And as we know, the use disorder is something that typically begins prior to those early adulthood years. So that's increasing the likelihood that this group of young people may be developing a lifelong problem. Okay, moving on to number 3, cannabis, also known as marijuana. Cannabis is a hallucinogen, so this is a completely different class of substance than what we've talked about before. It operates on the cannabinoid receptors in the brain. So for any substance to have an effect on humans, it has to be able to impact an existing receptor or chemical within the brain. Otherwise, there's no way for it to have an effect. And so alcohol has an effect by impacting those GABA receptors that we talked about earlier. And cannabis takes its effect by impacting the cannabinoid receptors in our brains. The active or psychoactive ingredient, I should say, is THC. So this is the chemical that is responsible for the psychoactive hallucinogenic effects of cannabis. And that's kind of the ingredient that puts cannabis in this particular category. Intoxication is diagnosed by the presence of 2 or more of these symptoms, which include conjunctival injection, a really fancy way of saying red eye, increased appetite, dry mouth, and tachycardia or a fast heart rate. Withdrawal is diagnosed by 3 or more of the following: irritability, anger, or aggression, nervousness, anxiety, sleep difficulty, more specifically insomnia, decreased appetite or weight loss, restlessness, depressed mood. And then we may also see physical symptoms as well, which include abdominal pain, tremors or shakiness, sweating, fever, chills, or headache. Cannabis is the most widely used illicit psychoactive substance in the United States, with 1 to 3% of the adult population meeting criteria for a use disorder. So that's not the number of people using the drug, that's the number of people being diagnosed with the disorder. Again, more commonly, we're going to see this behavior among males than females, and that's a really common thing, really across, I would say, the substances, for some of the emotional coping reasons that I shared earlier. Much like tobacco, the common age of onset for this is during the teenage years, and again, much like tobacco, vaping is really upping this trend. Despite having a benign reputation, I do always want to point out in these types of classes that cannabis is not a completely safe, non-addictive, whatever kind of drug. Long-term use is associated with impairment in learning, mood, and even the onset of anxiety disorders or potentially psychosis. So there are definitely some long-term consequences to heavy use, I would say, heavy, regular, long-term use of this drug. However, that being said, this is a really unique substance in that it does have medical benefits, which is what led to its medicinal legality, which has been opening the door more recently to recreational legality. Some of the things that cannabis can be helpful with are providing relief from nausea and appetite loss for those going through chemotherapy as a cancer treatment, or even for those struggling with those symptoms associated with the treatment for AIDS. Reduction of eye pressure for those experiencing glaucoma, reduction of muscle spasms for those experiencing multiple sclerosis, and decreasing the experience of pain for those experiencing chronic pain. There is also a separate related substance that people may consume called CBD, which is basically a version of cannabis that has the THC removed. So all cannabis has CBD and THC in it. As I mentioned before, THC is the psychoactive component of cannabis that contributes to the hallucinogenic properties of the drug. And recently, the THC it's been made possible to remove the THC from the CBD in cannabis, creating this legal product that doesn't have the hallucinogenic properties of THC. CBD by itself is legal in all 50 states. And the bulk of the research available to us now indicates that the main area it may be helpful with is seizures, but research is still coming out regarding other areas, including insomnia, pain, anxiety, and nausea. Up next, we have opioids. Opioids are derived from the opium poppy, and they work by mimicking our body's naturally occurring endorphins. And they include things like methadone, codeine, morphine, and heroin. The way that I always learn to kind of associate the types of drugs that fall in this category with their mechanism of action is that endorphins actually got their name from morphine. Endorphins mean endogenous morphine. So we actually kind of discovered this one drug before we named the neurotransmitter that it has an effect on. But that was kind of how I always learned to connect some of these concepts in my head. Endorphins are natural painkillers, basically. And so these various drugs that all are derived from the opium poppy had these kind of pain-killing types of effects. Intoxication is diagnosed by the presence of constricted pupils, plus one or more of the following: drowsiness or coma, slurred speech, impaired attention and memory. And then withdrawal is diagnosed by the presence of 3 or more of dysphoric or sad mood, nausea and vomiting, muscle aches, crying or runny nose, dilated pupils, or goosebumps on the skin or sweating. Overdose is something that a person can experience really across any of these categories, but I'm choosing to cover it in the context of opioids because that is really what's contributing to the opioid epidemic, is people dying of opioids. And interestingly enough, overdose is something that is more likely to occur in a new or novel environment. And I like to highlight this particular fact and why it happens in this class, because the reasoning actually kind of connects with some of the other classes taught in our psychology curriculum. So it's an interesting kind of cross-disciplinary type of topic. So ultimately, the reason that overdose of any drug, but again, in this particular scenario, we're talking about opioids, the reason that overdose is more likely to occur in newer environments is because a person typically builds their tolerance in a familiar environment. Like, let's just say that we have a person who started using OxyContin in their apartment, and they began using OxyContin because of a physical injury, and they were prescribed this drug in order to help with pain. And so they began using this drug in their apartment routinely. Ultimately, let's say that they didn't have access to this prescription anymore, but were addicted. And so at this point, they began to switch to an illegal street version of the drug, which would be something like heroin. So again, they're using this drug routinely in their apartment, someplace that's familiar to them. And what happens is the body eventually learns to associate cues, I guess, of the apartment as indicators that drug use is impending. So the body basically learns to associate smells, sights, sounds, people that are commonly in the apartment with impending use. And proactively, the body takes steps to counteract the effect of the drug. And so ultimately, the person is able to use more of a drug at home because the body is kind of helping them out and counteracting the drug to prevent overdose. However, in a new environment, these environmental cues are unavailable. So we're in a new place, we don't have these familiar smells, sights, sounds, people, and so the body doesn't really know that drug use is imminent. As a consequence, the body's not able to counteract the drug, and the person mistakenly uses the same amount of the drug that they've always used. But at this point, because the body's not counteracting the drug, that same amount of the drug now pushes the person over into overdose territory. And so ultimately, the reason that overdoses are more common in new settings has a lot to do with classical conditioning, the association of one stimulus with another and the body learning to counteract a drug in certain settings, but not in other settings. And so an amount of a drug that was safe in a familiar space is now unsafe in a new or novel situation. And again, this is a biological, physiological process that you'll see with other drugs as well, but I like to kind of talk about it in the case of opioids just because of the relevance. Opioid use disorder requires, so the diagnosis requires illegal use of opioids, so no medical condition or using an excessive dose if a condition is present. It typically occurs in younger people, those in their teens and 20s, males, and it's really common in pain patients. That's kind of the gateway that most people enter into opioid use through. It often begins with a prescription medication for pain. The prescription expires, as in the example I provided you earlier, and it may progress to the use of street opioids like heroin. There's a decreased prevalence of opioid use disorder with age. There are a couple different reasons for this. One would be mortality, people dying of overdose. Another could potentially be people maturing out, finally going to rehab, that time that works, which may be the 5th or 6th time that they've gone. And so people basically end up either dying or eventually kind of maturing out of the disorder. And then finally, we have stimulants. Stimulants work by increasing the levels of dopamine, serotonin, and norepinephrine in the brain. And so stimulants end up having the opposite effect of what we talked about in the depressant category. So the opposite effect of things like alcohol. So stimulants work by really activating the central nervous system versus inhibiting it. Things that are included in this particular category are things like amphetamines, cocaine, crack. Amphetamines include methamphetamines, MDMA, ecstasy, Molly. These are all things that are going to be existing in the stimulant category. There are also other things like caffeine, but caffeine typically isn't really included in the diagnostic category because much in the way that tobacco intoxication isn't really a thing because it's not associated with problems. Caffeine isn't really included in the DSM, even though it is a stimulant, because caffeine as a specific drug isn't really associated with significant problems as far as use, intoxication, or really withdrawal go. That doesn't necessarily mean that caffeine use can't be problematic at all. It is possible to overdose on caffeine. It just takes a lot to really do that. But I just kind of want to point that out, that caffeine is considered a stimulant, but it's not really something that exists in this diagnostic category because of it doesn't really have significant problems associated with it. Intoxication of stimulant is diagnosed by the presence of 2 or more of the following: tachycardia or bradycardia, which means a fast or slow heart rate, dilated pupils, high or low blood pressure, sweating or chills, nausea or vomiting, evidence of weight loss, psychomotor agitation or retardation, muscular weakness or respiratory depression, a difficulty time breathing, chest pain, cardiac arrhythmias, confusion or seizures, dyskinesia, dystonia, or coma. Dyskinesia and dystonia are kind of tremor-like symptoms, or a person kind of losing muscle tone. Withdrawal is diagnosed by the presence of a dysphoric or sad mood plus 2 or more of the following: fatigue, vivid or unpleasant dreams, insomnia, hypersomnia, increased appetite, psychomotor agitation, and retardation as well. So those are going to be your symptoms of intoxication and withdrawal. And again, a person could be using any of the specific substance I listed earlier. At the end of the day, though, I want to reiterate that what a person would be diagnosed with in this scenario is a stimulant use disorder, regardless of the specific substance that we're dealing with. So cocaine would be stimulant use disorder. MDMA, stimulant use disorder. Stimulant use is unique in that we have a variety of substances in this category. versus just one. And so we've got a real variety in terms of the types of use, the patterns of use. Stimulant use disorders, that should be an S and not a C. Stimulant use disorders develop rapidly, particularly when dealing with amphetamine stimulants or cocaine. Sometimes they can develop within a week, which is very, very quick. It would take much longer to build up a tolerance, other associated symptoms with like alcohol or some of the other substances that we've talked about. Particularly if the substance, if the stimulant in this scenario was smoked or taken intravenously. Those are two ways that really contribute to a disorder developing quickly. Use typically develops during early adulthood, so a little bit later than tobacco or cannabis. Long-term use is associated with heart complications and seizure. And then, as I mentioned earlier, while caffeine is a stimulant, it is considered separately from the other stimulants in the DSM, and is only and doesn't have an associated use disorder. So it is a stimulant. It functions in the same way as stimulants, but because of its relatively benign nature, it's not really associated with the stimulant use disorder. Finally, there are several behavioral addictions that are worth noting as well. Behavioral addictions are going to be patterns of dependence associated with behaviors rather than a substance. So a person becomes dependent on gambling or sex or internet use or something like that, rather than becoming dependent on a substance. Behaviors have the ability to produce short-term positive effects in the same way that substances do. So kind of like that intoxication or that high that we talked about earlier. And these positive effects increase the behavior's frequency despite associated negative consequences like STIs, losing money, losing time, impaired relationships, et cetera, et cetera. As of 2013 and the publication of the DSM-5, gambling disorder is the only non-substance related addictive disorder in the DSM-5. So gambling disorder is it as far as tangible behavioral addictions that can be diagnosed right now. Other possibilities that were considered as part of work groups but ultimately didn't make the cut include things like kleptomania, compulsive shopping, hypersexuality, tanning, internet use, computer, video games, things like that. Typically, if I'm teaching this lecture in class, I have you guys break out into groups and kind of research what some of the work groups were finding as far as some of these other possibilities go, and compare what you are able to find out about those behaviors with the symptoms of behavioral addiction. And then I'll also kind of have us talk about why the symptoms of behavioral addiction are so similar to this symptoms of substance-based addiction. At the end of the day, we're obviously not doing that given the current medium of the class, but I do want to point out the symptoms of behavioral addiction, which are listed here on the slide. Things like engaging in a behavior for larger, longer periods of time, desire or unsuccessful efforts to cut down on the behavior, a lot of time spent preparing for, engaging in, or recovering from the behavior, cravings, failure to fulfill major role obligations, continued use despite problems, giving up activities because of the behavior, using the behavior in dangerous situations like racking up huge gambling debts, or continued use despite knowledge of a problem. These may sound really familiar because they're basically the symptoms of a substance use disorder, but we're kind of replacing the phrase substance with the phrase behavior. And then obviously we're not dealing with pharmacological criteria like tolerance and withdrawal. You may see people gambling more and more and having a really difficult time going without, but there's not that link in terms of cannabinoid receptors or GABA or the specific neurotransmitters that various substances are acting on. At the end of the day, though, the reason that behaviors in substance-based addictions are so similar is because even without ingesting anything into the body, behaviors have an impact on the neurotransmitter dopamine. So even though a person with gambling disorder isn't ingesting anything, Gambling increases increases dopamine in the brain, and going without gambling does kind of send a person into a dopamine version of withdrawal. And so for that reason, these behaviors are really, really similar to the substances we talked about, because we're still dealing with behavioral activation of this one neurotransmitter, specifically dopamine. So those are really the takeaways from this slide, are dopamine and the notion that the behavioral symptoms are really the same as the substance use symptoms we talked about earlier. In terms of possible causes of addiction, there are several. There are genetic explanations. For example, the D2R2 allele decreases dopamine naturally, and it's estimated that about a quarter of the population may have this particular allele. So basically, if you've got a person walking around with lower levels of dopamine, this could put them at risk for an addictive disorder, substance or behavioral, as a way to increase those low levels of dopamine. There are also social theories as well, including peer pressure or classically conditioned social cues like out drinking with friends, and so why not smoke as well, for instance. There are the rewarding aspects of use. So those rewarding, pleasant, positive feelings that you get from milder forms of intoxication, like euphoria, relaxation, improved concentration. So these are reasons that people may persist despite later negative problems. Another reason that people continue to use has to do with the perceived likelihood of pros versus cons. Most people can acknowledge that, yeah, these substances can be addicting. I may encounter problems as a consequence of use, but I don't really feel like that's going to happen to me. I feel like I'm going to have the positive effects, and the negative effects are relatively less likely. So I'm not going to focus on those negative effects as much, and I'm going to use anyway. There are also some buffers as well that play a role in the likelihood of addiction. Strong ties to social constructs like church, school, things like that, work. These can really help to buffer against addiction. In the same vein, strong positive social influences from parents and peers can also help to buffer against addiction. But negative social influences are, of course, strong enough to counter some of those buffers, as in the peer pressure example. Clinically speaking, one of my favorite models to conceptualize where a person is with respect to their addiction and to plan treatment is the stages of change model. This model basically says that there are 5 different stages a person can be at with respect to behavioral change. And this could be any behavioral change, whether a person is considering exercising or changing their diet or sleep, but more relative to this particular subject, whether a person is going to quit use of a substance. And it's important to take note of where different patients are, because this can help inform what we're going to do as clinicians. So pre-contemplation is when a person isn't even really thinking about changing what they're doing. Contemplation is when they're thinking about it. Preparation is when they've decided to quit, but they haven't quit yet. They're making plans. Action is quit day. And then maintenance is the really important stage that a lot of people don't think about. They think about kind of quitting and quit day, but not how to continue to stay abstinent, because it's really not just one decision that you're making one day. It's continuing to make that decision every day thereafter. And not maintaining the process of quitting a drug really just leads to relapse and kind of going backwards. And so one of the things that I always do with clients when I'm working with them regarding substance use is something called relapse prevention. And relapse prevention is really just about talking about how relapse is really common, and that there's a difference between a relapse and a lapse. A relapse is kind of going all the way back to ground zero. You have a drink and it's like, oh, I screwed up, I might as well have 10 more drinks and keep drinking tomorrow and the day after and the day after. And this idea of relapse kind of comes from a zero tolerance policy. It's a policy you see a lot in like 12-step programs where, you mess up and now you're back to your one-day chip. versus I like to tell people that there's a difference between a relapse and a lapse. A lapse is just a lapse in judgment. It's having that one drink and then deciding that you made a mistake and stopping. So I really like to educate people about the difference, that relapses and making mistakes are common. Or I should say making mistakes are common. What makes the difference between a relapse and a lapse is your reaction to that mistake. Are you choosing to catastrophize and spiral out of control and go all the way back to ground zero? Or are you choosing to acknowledge this as something normal that happens to humans? Humans aren't perfect, and to just kind of have that mistake be what it is and to continue. I'll frequently tell people also that the only alternative to these lapses or mistakes is to literally go the rest of your life never making a mistake in this area and being completely perfect. And when I say that, it really seems to dawn on people like, oh yeah, that is pretty unrealistic. Like, it could happen, but unlikely to go decades of your life without making a mistake in this particular area. And so it's better to just acknowledge the realistic likelihood of mistakes and to prepare, talk about what to do if you do make a mistake, so that you have a plan and that you're prepared to not get so down on yourself, which can really make the situation much, much worse. Other types of treatment approaches include aversion therapy, which can also be used for other categories of disorder, including the paraphilias, which are something we're not really going to cover in this class just because of really time reasons, but you're welcome to read up on them in your textbook if you have your text and you're curious. Aversion therapy is basically a form of therapy where we teach a client to associate something aversive with the consumption of a substance. Antabuse is a good example in this scenario. It's a medication that when taken regularly will induce vomiting or nausea when alcohol is consumed. So that's a way to make the experience of alcohol very aversive. We can also implement substitution in acutely dangerous situations. So this would include using benzodiazepines to help people through alcohol withdrawal, or helping people move from the use of like heroin potentially to methadone as a form of medication assisted treatment for that particular drug. Psychoeducation can also be important, talking to people about how overdoses are more likely in novel environments, to educate folks on, you don't have this fixed amount that you can use safely, but the safe amount you can use varies depending on the situation, and you might need to mix it up if you're going to continue to use. The danger of prescription medications, I always talk about that with pain clients that I'm working with, and safe disposal of old medication. We touched on that when we went over suicidality in the context of mood disorders. And then, of course, there are always the 12-step programs like AA or NA that focus on abstinence and social support. It's important to recognize that these are not empirically based programs. These are just kind of created by two guys who found that social support and abstinence were helpful and kind of came up with their own program. But the reason I always highlight them in this class is because they're free and they're literally everywhere. So it's important to be informed about them because you may be working with a client who maybe can't afford to see you more than 6 times. And so you might have to kind of get creative and work in other types of approaches to give this person a form of support. Some people like them, some people don't. Some people are turned off by the religious emphasis, which proponents will say isn't there. There is reference to a higher power, but it can be difficult to envision what a higher power is outside of a religious context, given that most of the time when we're talking about higher power, we are talking in a religious kind of context. So for some people, it can be difficult to kind of separate those pieces out, and that can be kind of a turnoff, but for other people, they really like it. And again, because they're free and they're everywhere, even if only half of the people who join end up liking it and sticking with it, it still is a huge number of people and a huge reach. And there again, there are people who really like it. It does work for some folks, and it is free and it is everywhere. So it is important to kind of be versed in this area if you do end up working in the substance use niche. And that is all that I have for you guys.